now we start our talk. This talk is about 2020 International System for Reporting Serous Fluid Cytology. And I'm Mark, very thankful for the invitation from Thai Society, especially President Song Boon, kind invitation and sponsor to me. Thank you, Thailand. And I really look forward to visiting again and again every year, just like previous time. And I disclose no conflicts of interest. And this talk is contributed also from President Ash. President Ash is the major editor of International Serous Fluid Cytology editor. He's co-worked with Barbara and Daniel and Fernando. They are core editors of this book. And this book is a collaborative work with IAC to AXC collaboration. And this is a great team from, from Asia to Latin American and Europe. They survey many of the experts and respondents, and then they conclude a consensus book to categorize the serous fluid cytology and to make a consensus to reporting this kind of serous fluid cytology. And then the first announce is coming from Acta Cytologica. Dr. Ash and Barbara and Daniel and Fernando, they are core editors to announce the launch of International System for Reporting Cytology. And you can get this book in at Springer bookstore, or you can download by hardcover or ebook. Personally, I buy an ebook because I think the ebook is pretty good for prepare this talk and to teaching students. So I will recommend you to buy an ebook. If you prefer hardcover, old school man, you can also buy a hardcover because hardcover is also very cheap. And why we need this terminology system? Because we need to evaluate the adequacy. The adequacy is always a big issue for, for pericardial effusion, pleural effusion ascites. How many modern, how many cerebrillarity is worth reporting? This is, great issue to discuss and need to establish a consensus. And then we should define what is a true negative sample. A true negative sample is meaningful. A false negative sample will miss the diagnosis. So we should define what is true negative. And the use of atypia and suspicious. About atypia and suspicious, they are borderline diagnosis. We should divide them more strictly, more seriously. And then we will discuss about the mesothelioma. About the terminology of mesothelioma, in this reporting system, we are all totally recruited in positive for malignancy primary. And peritoneal washing is also need to further discussed in this book. But today, this talk, we want to mention peritoneal washing too much. And first, we need to introduce how many categories in this terminology system. We have 5 categories. As you know, we have non-diagnostic because we need to define what is adequate, what is inadequate. And second, we have negative for malignancy. And third, we have atypia of undetermined significance with so-called AUS. Just like a cervical pap smears, we also report AUS. And 4, suspicious for malignancy. And 5, malignant primary, malignant secondary. And 3 parts of the report we need to mention. First, we need to mention the adequacy. And second, we need to define which diagnostic category this sample is classified into. And third, the clinical comment. We need to give them clinical comments to guide the clinical doctors to do something. For example, in lung adenometastasis, we need to pursue them to do molecular tests. But for a true negative sample, we need to emphasize this is true negative, not false negative. You don't need to collect again. So let's go for the first issue about adequacy. There are three factors about adequacy. The first factor is sample volume. How much is a recommended volume for fluid sample? Generally, I think especially by Hopkins article, the Rupert published in 2014, 75 milliliter is generally accepted to be an ideal volume we think to have the most effective and most sensitive reporting. But for pericardial fluid, we just need 60 millimeter. So these two are ideal and optimal volume. We try to recommend a clinical doctor to give us adequate volume, and then we can do something to do the molecular test or to do the extraordinary test. So especially if you have optimal volume, you can also recommend the clinical doctors to do something more than cytology, especially at the time of collection. This is very important because after collection, something may change. So if you need to do something, you can recommend the clinical doctor to divide them in the beginning. And second factor for adequacy is the cellular content. Do we really need mesothelial cell in every pericardial or pleural effusions? The answer is no, because in tuberculosis, in chirus effusion, we accept only lymphocytes. And in empyema, we accept only neutrophilic effusions. So not in every case, we need to see mesothelial cells. But you should make sure these cellular contents are meaningful, especially in this clinical scenario. So about the malignancy, they for sure don't need to make this kind of diagnosis with mesothelial cell. They can make this kind of diagnosis without mesothelial cell. And the third factor about adequacy is the preservation. This is very important for adequacy. Every sample loss of quality, such as degenerative change or delayed transportation or overgrowth of bacteria or poor fixation, poor preparation or technical artifacts. Anyway, if you look at these slides and you feel very sad, you cannot read it very well, even you try hard. You can report it's inadequate because it's loss of the quality. This is very important because in the consensus, a sample without quality, we cannot make any diagnosis confidently. And for sure, this kind of sample should be classified into non-diagnostic. This talk will be oriented by case-oriented way to introduce our 5 categories. And now let's try to follow case 1. Case 1 is a 54-year-old man with left side pleural effusion. He's a heavy smoker, cough and chest pain for 1 week. But even he's an old smoker, he have unilateral pleural effusion. The clinical doctor only sent 2 milliliters of bloody fluid to our laboratory. And we only prepare 1 thin prep and 1 deep creek dry cytospin preparation. And this is the thin prep. You can see the thin prep is almost a bloody tangled slide. and the celerity in growth is not easy to pick up the particles or the cellular clusters. And then in simple pap stain, you can see, wow, it's bloody and very hazy. You cannot see viable cellular clusters or cellular aggregates. And this is dry stain. In dry stain, you can see the degenerative RBCs and neutrophilic cellular clusters, but only inflammatory cells. But anyway, you can see mostly they are, red blood cells, and they are inflammatory exudates. You cannot easy to find out the other meaning for, clusters of cellular fragments. This case is a heavy smoker, have unilateral pleural effusion, strongly suggests maybe something wrong, but he only give us 2 milliliter, and subsequently the 2 milliliter give us only red blood cells and inflammatory cells. So for sure, it may not be representative. So how to report this kind of case? You can report. This evaluation is very limited because by heavy blood staining, and is very likely to be non-representative sample, we classify it into non-diagnostic category. And we recommend a clinical recommendation. We could recommend a clinical doctor to repeat collection, repeat the sampling, and the 75 milliliter volume, if possible, is appreciated. The second case we will go into come with 64-year-old male with liver cirrhosis and ascites. Gross pictures, we got 60 milliliter strawberry color fluid, and we prepared 2 cytospin, pap smear, and Giemsa stain. So this is a cirrhotic man, and he have no remarkable tumor mass, but a lot of ascites. And we have at least 60 milliliter ascites. And in Giemsa stain, you can see, wow, this is mesothelial cells. Yes, I look at this mesothelial cell, but they look by morphology acceptable. And the background have a few lymphocytes. And you can see the neutrophilic infiltration is a bit increased and even much cellular than the other samples. So this case, we cannot see remarkable atypical cell or tumor cell, but normal population of mesothelial cell, lymphocytes, and neutrophilic aggregation. So this case probably may be normal. And in pap stain, you can see, yes, this is characteristic of mesothelial cells, and atypia is very minimal. Neutrophilic infiltration, yes, correlate to the Giemsa stain. And lymphocyte, yes, they have mild infiltrate. And without remarkable lymphoid, atypia. So how to report this kind of ascites? We first mention the adequacy and the quality. Is satisfactory for evaluation, good. And in mostly neutrophilic and mesothelial cell and the lymphocyte infiltration. And we decide to classify it into negative for malignancy. And lastly, the clinical recommendation. Because a higher proportion of neutrophil infiltration in this case, so we may, recommend them to worry about the spontaneous bacterial peritonitis to exclude the possibility of SBP, especially symptomatic ascites. So for negative malignancy, our category 2, in a category 2, we expect a normal cell population in pleural effusion or in ascites. What is the normal populations? They are lymphocytes, macrophages, mesothelial cells, and neutrophils. And even in eosinophilic peritonitis or ascites, you can see a lot of eosinophilic cells. About the pattern of reactive effusions, we can divide them into eosinophilic effusions, lymphocytic effusions, and neutrophilic effusions. And their definition generally, you can see eosinophil over 50%, lymphocytes over 50%, and neutrophilic infiltration over 50% of normal nuclear cells. So about the eosinophilic effusion, you can consider the recent fluid aspiration or allergic diseases, including hypereosinophilic syndrome, etc. About the lymphocytic effusion, you can consider tuberculosis, heart failure, or viral infection, or hemodialysis. It also have a lot of lymphocytes sometimes. And for neutrophilic effusion, you can consider empyema, especially active bacterial infection, sometimes malignant lung squamous cell because they have a remarkable tumor necrosis, can rupture into pleural cavity and create neutrophilic effusions. So the pattern diagnosis is also important, especially in the negative for malignancy. You can give precisely clinical recommendations. Now we go with the case 3. The case 3 is 46-year-old female with history of breast cancer 6 years ago. Now she complained of cough, and he have in X-ray that she has a small pleural effusion, and we got 20 milliliter relative suboptimal strawberry color fluid. We prepare cytosplenic impact stent and GIMSA stent. This is GIMSA stent, modified GIMSA stent. You can see, yes, this probably mesothelial cell, this probably mesothelial cells, but this is probably lymphocytes. But these cells are pretty, poorly preservation or maybe artifacted, so not easy to evaluate. And next, in PET stent, we see some atypical cell, but they are, pretty scattered, very few, but we still can see them with hyperchromatic nuclei, high NC ratio, nearly have very scanty cytoplasm, and abrupt with background cells. They are, very, eye-catching in the slide reading. So how about this, how about this scattered atypical cell? How can you, mention them or classify them? This is why we have AUS. Sometimes we can occasionally get these poorly preserved cells with nuclear enlargement, nuclear hyperchromasia, but the chromatin or nuclear membrane anomaly is not remarkable, but we still worry about these kind of cells. So most of the time, these cells are macrophages or mesothelial cell with degenerative change. But maybe in the minor conditions, they are truly tumor cells. So we need cell blocks or ICC, immunocytochemistry, to detect they are metastatic epithelial cells such as metastatic squamous or metastatic lung adenoma. And by the general recommendation, you can use a BERI P4, MOC31, And Claudin-4 recently it's more, appreciated as a sensitive marker for, metastatic adenocarcinoma. And in many metastatic carcinoma, such as breast, lung, or ovary or stomach, you can see if you use a panel of BRP4, MOC, and Claudin-4, you can detect them out, especially apart from mesothelial cells, because these proteins are epithelial cell adhesion molecules. So this case can be a first screener to pick up they are problematic atypical cell, and the others are non-problematic atypical cells. If this staining panel is R negative, you can downgrade atypical to negative for malignancy. If any of one positive, you should further survey is this atypical cell are meaningful or not. And in this case, we have cell block. And in the cell block, most of the, the cells, even some cells are a bit atypical, but after fixation, we can see they may be more like a mesothelial cell. And we do staining of BRP4, and BRP4 is negative. The other stain are also negative, so we recommend to emphasize this atypical cell may be normal mesothelial cell with degenerative changes. So for AUS is a borderline diagnosis. In the IAC and ISCC survey, they are this category is uncommon used as a diagnostic category, especially some experienced cytologists didn't use it at all. But they are discussed about, should we keep the AUS? Most of the respondents tell us they still use it, especially some, in some cases, they cannot decide they are truly positive malignancy or not, or just reactive. So, in a consensus, we recommend a two-step process. You can pick up this scattered atypical cell in a preliminary report as the first step. And then if you get adequate sample, prepare a cell block and do some stance, then you give a final report to suggest it's a reactive process or neoplastic process. So the algorithm will come into this algorithm. There are small number of atypical cells, probably macrophages, mesothelial cells, epithelial cells, and you can sign out a preliminary assessment as AUS. And if you have ICC, slice, or cell block, you can do staining. And if you make sure they are mesothelial cells or macrophages, you can downgrade the AUS to negative for malignancy. If the atypical cells are, after staining, they are epithelial origin, maybe they are metastatic lung adeno, you should report them as suspicious for malignancy or positive for malignancy metastatic. If you don't have adequate samples, you have inadequate slides to do ICC stain, you can just report them AUS as a final diagnosis. That's why we keep AUS, because we may have these three scenarios. If you have adequate sample, we do stain to divide it positive or negative. If you don't have, we need it. Most of the time, if we don't have adequate sample, we need AUS to keep this diagnosis as a borderline decision. And then we come with the case 4. The case 4 is a 68-year-old man with ascites. He has a history of lung cancer. We got grossly a 30 milliliter of bloody tangled fluid. And you can see this cellular cluster compared to the background lymphocytes and even macrophages or mesothelial cells. Every atypical cell are pretty large. And you can see their NC ratio is relatively low, but they have vacuolated cytoplasm. And this cluster may get 1, 2, 3, 4 cells together. So it's pretty, it's pretty impressive because it's pretty large, and the cytoplasm is characteristic not fulfill the mesothelial cells because they are vacuolated. And then in PEP scan, you can see more clusters, and they aggregate together, and you can also see vacuolation, although not pretty clear, but their size apart from length are much larger, especially compared with RBC. Each cells are at least 3 or 4 times larger than RBCs. So they are large cells and low NC ratio with vacuolated cytoplasm. So you can think them these cells as a typical cell or true neoplastic cell. But anyway, you need to do stents. So because the size is pretty large and the cytoplasm is vacuolated, we consider maybe they are adenometastatic. So my preliminary assessment is suspicious for malignancy, although the cluster are not cellular, and we need ICC to confirm it's a malignancy. And if I don't have adequate sample, I will still report it as suspicious for malignancy. So suspicious for malignancy algorithm is also have the same direction with the AUS. We give a preliminary assessment. If you have adequate sample, do something. If you don't, just report your assessment as suspicious for malignancy. And this is cell block as our impression about the metastasis. This cluster has a clear vacuolated cytoplasm and relatively lower NC ratio. So we do some adeno stents, and it's positive for TTFF1. So we recommend it come from lung adeno. So in our report, we will report, yes, it's a satisfactory adequacy, and the ICC, TTF1, and Nexin A are positive, and the suspicion for malignancy upgrade to positive for metastatic lung adenocarcinoma. Ancillary tests, especially for lung adeno, we should always keep in mind, because lung adenocarcinoma is not only for diagnosis. We need to keep more samples for ancillary tests, especially for molecular testing. So about the use of IHC panel, we recommend to use the IHC panel as limited as you can. So you can only stent TTF1 Nepsin A P40, or even you can replace Nepsin A as INSM1 if you consider small cell or neuroendocrine carcinoma. If you strongly want to pick up the lung adeno, you can use 2 lung adeno stenting as your preliminary or preferable panel to pick up. Anyway, restrict use. Use it limitedly. Keep the sample to the further molecular testing. And about the category category 3 AUS and category 4 suspicious for malignancy, we should know their dramatic meaning. The AUS, we expect their risk of malignancy around 20%. But for suspicious for malignancy, we expect the ROC is around 80%. They means AUS in most of cases are reactive. Suspicious for malignancy in most of cases are positive malignancy. So the outcome usually malignant, but I don't have adequate sample or I don't have adequate quality to read them as positive. So I sign out them as suspicious for malignancy. But for AUS, most of the time, they are just reactive or degenerative changes from macrophages or mesothelial cells. But in minor condition, maybe they are tumor cells with regeneration. So both of the category need further investigations, especially through cell block or immunocytochemistry on slides. So these two borderline diagnoses are, very critical and have different meaning. One category favor reactive, one category more favor positive. Okay, let's go with the case 5. The case 5 is a 68-year-old man. He has occupational exposure to asbestos, and he has a unilateral hemorrhagic pleural effusions. We got a lot of 80 milliliter of blood stained fluid. We prepared cytospins and GEMSA and PEP stain and cell block. Before we read in this case, we should recall our impression about the mesothelial cells. Generally, mesothelial cell is larger cells, but they have, the outlier of a curtain-like cell membrane, and the NC ratio is low. And most of the time, the mesothelial cells, they have narrow space between each other because their outer membrane close together and creates this narrow space. And the nuclear tibia usually is not remarkable. They may be binucleated or multinucleated, especially in reactive changes. And back to our case, the case 5, you can see cellular fragments, and most of the cells, they have pretty, clear chromatin and condensed chromatin with a remarkable nucleolus. And the cytoplasm is relatively pale, and the cell-to-cell border have some, some narrow space. You can always see, wow, and they are monopopulation. It means they may be from the same cell lineage. So they probably metastatic cancer or mesothelial hyperplasia. And get closer in a high power, you can see all the cells, they are relatively monotonous and have narrow space between each other. So we prefer they are mesothelial cells, but the cellularity is pretty high. So we may consider a typical mesothelial hyperplasia. We need to rule out the possibility of mesothelioma. And cell block fixation, you can see the mesothelial-like cells, epithelioid cells, and sometimes binucleatic cells, and the background typical cells. About the mesothelioma or metastatic carcinoma, we should do a primary panel to pick them up. As this, we should divide them in the very beginning. So a good panel to start with is use 2 mesothelial marker and 2 epithelial marker and 1 macrophage marker as a panel to decide one direction we want to go further. So in most of the time, the panel would be WT1, creatinine, and MOC31 and BERP4 and CD68 is a good panel you can use as a pretty start step as as a direct guide. And then if you have MOC31 and BERP4 positive epithelial marker, you can go further with MOC4 and Claudin-4 to assure a certain they are metastatic adenocarcinoma. And then go further with specific marker with TTF1, nepsin-A, CDX2, PEX-A, GATHER3 in different specific sites. And we should consider about the condition of WT1 positive. Not every WT1 positive cells are mesothelial cells. We may have WT1 positive metastatic carcinoma, such as gynecologic tract cancers and breast cancers, especially basal cell type, and some squamous cell carcinoma. Maybe we have WT1 positivity, but most of the time they are focal positive. And GATHER3 standing also positive in 50% of mesotheliomas. So GATHER3 is not, we didn't recommend it as a primary screening marker panel. We should go further, we could use it as a site-specific after the primary screening. And about the squamous cell carcinoma and mesothelioma, both of them can be CK5 and CK6 positive, and maybe creatinine or D240 positive. So sometimes, both of the diagnoses are pretty, challenging, especially the sample is not adequate. This is the engineering test for mesothelial perforation. In the previous slide, I talked about the metastatic carcinoma versus mesothelioma. And this slide is about how about the benign mesothelial perforation and mesothelioma. About the benign mesothelial perforation, they are dexamine positive, EMA and HEC1 negative, and BEP1 nuclear staining positive, and MTAP and the 5-HMC, they are more new markers. They are positive or fish non-deletion. P16 CDKN2A fish are no deletion. But for mesothelioma, they are generally BEP1 loss, MTAP loss, and 5-HMC loss. So you can use these markers as screening marker and then confirm with BEP1, MTAP, and 5-HMC as conferable marker. Especially if you use any two of these three or use all of the three, you can assure a mesothelioma in most of cases. So it's there standing. Creatinine mostly in mesothelioma or benign mesothelial hyperplasia, they are positive. But for MTAP, BEP1 in mesothelioma, usually negative. This is the algorithm for diagnosis of malignant mesothelioma. You can guide with this algorithm. Pick up and exclude the metastatic adeno and the metastatic carcinoma by this panel, Claudin-1, BERP4, MOC31, and then go through the mesothelial markers with this guidance. And about the mesothelial hyperplasia, the sample report, we can, report this for the case 5, satisfactory for evaluation. We see groups and dispersed mesothelial cell with nuclear polymorphism and may be suspicious for mesothelioma. We do immunostains as the algorithms If the stain are positive for MTAP and BEP1 loss, we can confirm them as the mesothelioma. If the morphology classic but the immunostain are equivocal or cannot done, we just suspicious. If the immunostain cannot confirm and morphology is not classic, we just report a typical mesothelial hyperplasia. Okay, lastly is malignance. Malignant, I think only one policy. You have cellular specimen and the morphology is pretty characteristic. And you have cell block to do stents to confirm they are mesothelioma or metastatic. So the CAC6 is ascites. We do GINSA and PEP. Yes, in PEP stain, we can see pretty, pretty ugly, vacuolated, and sometimes signaling-like tumor cells with background of mesothelial cells and lymphocytes. And in GINSA stain, you can more confidently to see the vacuolated tumor cells and signaling-like in some cases, in some cells. In fixation cell block, we get more characteristic morphologies. And if you do the stain, yes, this case is positive for PAX8. So we recommend it may be from the gynec tract or the PAX8 positive other cancers. So in this case, we should do site-specific markers, such as to lung, to breast, to thyroid, to GI. We have specific marker you can go with. But firstly, you should pick up them apart from the primary mesothelioma by morphology or by stains. So a sample report for malignance is satisfactory for evaluation. This is for adequacy. And we got a group of the cohesive large cell with vacuolated cytoplasm and remarkable nuclear polymorphism. We for sure classify it as malignant. And immunostain report to assure the primary. Yes, this is the diagnosis category with our 5 categories from non-diagnostic, negative, AUS, suspicious, and malignancy. And after classify to the specific category, we need to go further with non-diagnostic to repeat the sample, negative for malignancy to discharge or just clinical follow-up. AUS and suspicious, we need to do the ancillary test to confirm with biopsy or clinical data. And positive, we need to do something about ancillary tests, especially molecular tests for specific tumor. And generally, in this reporting system, we got non-diagnostic ROM of 17% and negative for 20%, and AUX 60%, and suspicious 80%, and malignancies 19%. Is proposed and statistically number for the risk of malignancy. So you can see, especially even in non-diagnostic and negative for malignancy, we still got pretty higher proportion of malignant rates. So we need to take the adequacy very strictly. You cannot, easy to say this is adequate sample to read and just report them negative for malignancy because you may miss some false negative samples. And to close my talk, I will close with the practical approach for serous effusion. I want to thank Ava to provide this algorithm. You can prepare effusion, read effusion in the first step to evaluate the adequacy and then to expect and to read the cellular findings. If they are unexpected cellular findings, we do something outstanding. If they are expected cellular cells, we evaluate the volume and the cellular contents to to classify them into negative or into non-diagnostic. And then thank you. My first talk closed. And if you have questions, I'm very happy to answer you. And I have a future study in Taiwan with multi-center to collect data from different medical centers about the experience of reporting this international serious cytology terminology system. We do a retrospect collection. So if you want to join us as an international collaboration, I'm very pleased and thankful. Thank you.